Each year, about 14,000 people in the United States are diagnosed with cervical cancer, and around 4,000 die from it. Worldwide, cervical cancer is the fourth most common cancer among women and AFAB people, with over 600,000 new cases and more than 300,000 deaths annually. Hey y'all, welcome back. Today we are talking about cervical cancer screening. We're going to go into a little bit about HPV, Pap Smears, how we screen for cervical cancer, and why. If you are interested, I have a 3-part series on the HPV vaccine and what HPV is. I will link that in the description box down below. It would answer all of your questions with regards to what the virus is, how you get it, why you should be vaccinated, and all the questions and answers that people have regarding that. So that'll be a link below. It's very useful. But today's video is about cervical cancer screening, why we do it, when we do it, what you should know about it. Consider subscribing. A lot of you probably think you're subscribed, but you're not actually subscribed. If you're new here and this is the first video you've seen, I'm really happy to have you. I talk about all things periods, pregnancy, everything in between. Happy that you're here. Let's talk about cervical cancer screening. So what is cervical cancer screening and why do we do it? The cervix is the end of the uterus. So if you use a speculum to look inside the vagina, what you see is the cervix. It looks like this, like a circle with a dot in the middle. It's what people refer to when they say, oh, they're 8 centimeters dilated when someone's having a baby. That's the cervix that they're referencing. The cervix is an interesting piece of tissue with regards to the human body because it can harbor a virus called HPV or human papillomavirus. This is a really common virus that 80% of people will have at some point in their life, even if they've only been sexually active with one person. It is sexually transmitted, but not only via like penis and vagina sex. There are lots of ways that any kind of skin-to-skin touching, particularly near the genitals, can transmit HPV. So there's ways to get it if you have not been sexually active in the way that some people reference it, which is an off point, but why we shouldn't as healthcare providers just say, are you sexually active? The reason that some people have this and never know is because we usually don't test for it. And most people who get it, their body clears it on its own. So the way that I kind of think about this in practice or talk to people about it in the clinic is it's kind of like the chickenpox virus. Some people get chickenpox, they hold on to that virus, and someday they get shingles. Some people get chickenpox and they never get shingles. We don't know why people fall into one category or the other. HPV is much similar. You can have it and never know because we never tested for it and it never caused problems and your body cleared it on its own. You can test positive for a strain of HPV and it never causes your smears to become abnormal. You can test positive and your smears become abnormal. We don't really know for sure why people fall into one category or the other. We know some risk factors for not clearing HPV on your own. So people who are immunosuppressed, either because they're on medication or they have conditions that cause immunosuppression. We know that people who smoke are less likely to clear HPV on their own, but also sometimes we just don't know. And someone can be healthy, immune competent, never smoked in their life, and still not cleared on their own. We don't know. Why is cervical cancer screening even important? The first one is early detection. So if someone does have cervical cancer, catching that early through a smear is incredibly important because then we can treat it with less invasive measures and you're less likely to get advanced disease. The second, and actually arguably I would say most important reason to get screening is because of preventative measures. Cervical cancer is one of the only cancers that we can really accurately and with very high percentages prevent. Because if someone is getting smears, not always, but most of the time, we will catch a precancerous lesion well before it has time to advance to actual cancer. Again, not 100%. Sometimes people come in, they've gotten all the recommended screening, and they just had a really aggressive form that went from 0 to 100, and we didn't have time to do the screening that would have caught it. But by and large, we will catch an abnormal cell on the cervix well before it has a chance to become cervical cancer, as long as somebody has been coming in for their screening. So early detection and preventative measures in the way of identifying precancerous lesions and proceeding with treatment if needed are really important reasons to get cervical screening. The third one is that it improves survival rates. And this kind of goes hand in hand with the early detection. If you're getting screening and we catch cancer early, then survival rates are much higher. What is HPV? It is a common cause of several types of cancer: vulva, vagina, cervix, oropharyngeal, meaning mouth and throat, penile cancer, anal cancer, lots of cancers associated with HPV. Most of them in anything that lives near the genitals or in the mouth and throat. If you test positive for HPV, that doesn't mean you have cancer. And even if you have a smear done and it's abnormal, that doesn't mean you have cancer. I would venture to say most of the time when you have a positive result on either of those, that doesn't mean you have cancer. HPV is extraordinarily common. 80% of people will have it at some point in their life. That doesn't mean 80% of people will be able to tell you that they've tested positive for it, because your body clears it on its own in a lot of cases. But 80% of people, if you just randomly test everyone through their life, will have it at some point. We didn't used to test for HPV because there's like 100 and something different strains. But now we've incorporated that testing into our cervical cancer screening programs. So now, depending where you are, you might get a smear and HPV, you might just get HPV, you might get a smear and then HPV only if it's a certain result, or only if you're a certain age. There's a lot of different ways that these recommendations go. But in general, it's not of utility to just check for HPV of any kind without a plan. So that's why we're going to talk today about what goes into most cervical cancer screening. There are lots of types of HPV, and the HPV vaccine that we're currently using covers 9 of them. Some of the older ones only covered 2 or 4, and 2 of those are the most common cause of genital warts, HPV 6 and 11. 2 of those are the most common cause of cervical cancer, but also anal cancer, oropharyngeal cancer, and those 2 are 16 and 18. Those are considered high oncologic risk HPV. But there are so many others that can also cause smears to become abnormal or cause cancer. Now, that is why you can get the HPV vaccine and still get a strain of HPV or an abnormal smear. So that's why you still get screened even if you had the HPV vaccination. You're just much less likely to get HPV in general, and much less likely to get one of the forms that would be more likely to cause cervical cancer. Does that make sense? Like all vaccines, it's not 100%. So even if there weren't other strains, you'd still need to be screened. But there are so many strains, you cannot make a vaccine that covers every single one of them. So screening is still important. My recommendation to you would be to talk to your doctor or advanced practice provider where you live, because everyone who has a cervix should be getting cervical cancer screening of some kind. And what exactly you need, HPV, smear, or both, depends on how old you are, where you live, your personal history, etc. So talk to whoever takes care of you, but just know you need something at some point. So smear results can come back. They can say ascus, which is atypical squamous cells of unknown significance. This can be a normal result or an abnormal result. It's kind of pathology hedging on that. L-sil is a low-grade abnormality, and H-sil is a high-grade abnormality. You also might sometimes get one that's ASH, which is abnormal cells of unknown significant favor high-grade. So they're like, these look a little bit abnormal. I don't want to call it ascus because that can be normal, but I also don't want to call it H-sil because I'm not sure that it's high grade. We need to correlate clinically, essentially. And you can also get something called AGC, which is atypical glandular cells. And that is just another form of a high grade abnormality. Now, that essentially is a spectrum. So when I have a patient in clinic, I say smears come back on a spectrum. They go anywhere from normal all the way over here is cervical cancer. Many abnormal smears can get better on their own. However, a lot of abnormal smears, if left ignored over a period of time, will continue to progress to cervical cancer. So that's why it's important when we get an abnormal result to follow up either with biopsies or treatment or continued surveillance, depending on what the result is in your individual history. So what I tell my patients is the most important thing is don't disappear. You just have to come back at the timeframes that we recommend or at least let me know what's going on if you are not doing that or don't want to, so that we can make sure we're taking the best care of you possible. Because we can, without 100% certainty, but with fairly close to that, relatively certainly prevent things from advancing to cancer if we just do the recommended follow-up and treatment like we have data and literature to suggest we should. What do we do if you get an abnormal smear and or HPV test? The next step would be something called colposcopy. Now, colposcopy itself sounds real intimidating, but it's actually just looking at the cervix with a microscope. So it's not any more painful than just getting a smear, the colposcopy itself, because colposcopy itself is simply being in that awkward position with your legs up and letting us spend a little bit of time looking at the cervix through a microscope. I really love the setup we have in our clinic. If I can, I'll throw some B-roll in here, but I don't know if I'll be able to, where we have a monitor that the patient can see what I see through the microscope, which is both to me really cool because I can tell them what I'm looking at, but also we know in the data on this topic that having that monitor where they can see what I'm looking at decreases their anxiety with regards to any recommendations, biopsies, or treatment. And it's a great educational opportunity. I love it. The colposcopy itself involves looking with a microscope and applying some acetic acid, which is quite literally vinegar, to the cervix. And that allows the cells that are abnormal, if they are there, to be seen more readily through the microscope. So we put acetic acid on the cervix, leave it for about 45 seconds to a minute using a cotton swab, and then take that off and look through the microscope. Those cells will then be visible kind of as a white color if they are present. And then another step in colposcopy is looking with a green filter, so changing the microscope to see through a green light, and that helps us see abnormal vessels. And then another step is using a high concentration iodine called Lugol's to put on the cervix, because that also helps us see abnormal areas. That's the colposcopy. So when you see people talking about colposcopy being painful, they're usually talking about biopsies. Now, I have an issue with that because I think that a lot of why people find colposcope biopsies painful is because they, one, have somebody who is not listening to them and not explaining things, not prepping them, not going over anything, and just generally it's poorly communicating. We know that anxiety and lack of information increases somebody's discomfort with any kind of medical procedure, but specifically we have data on that with regards to colposcopy and biopsies. I use a topical numbing medicine. Admittedly, the data on that is questionable, but in my practice, I have seen that that is very helpful to my patients, and I use it every time if I'm doing anything that involves an instrument or a biopsy or anything on the cervix. I always use a topical numbing medicine. This is easy to do, and I don't really think there's any reason that people should refuse to do that if asked. Should we be doing like injectable medicine to do biopsies? I actually don't think so. My patients have across the board given fairly good feedback to me that I would think that that would be way too much, because that injection hurts and oftentimes is not needed, and people do great with the biopsies. But if someone is highly anxious and they would rather have a block, we can talk about that too. I think there's a whole lot of discussion around the pain related to procedures on the cervix, IUD placement, etc. And this is an open place for conversation. We don't have great data that indicates anything works really, really well. So my personal philosophy is I'll do what I have found to work well for my patients. But if you have something specific you want to talk about, or you're more anxious, or whatever, like, we will talk about it, and I will do whatever it is that you think would be the best for you, knowing that some of those things do have risks, like doing a block does have a risk. Injections of local anesthetic do have a risk, but they also may have a benefit. The data is not clear that there is a universal benefit to any of these things, so it needs to be an individual decision-making process. However, the process of good communication, letting patients know you're in charge. If you need me to stop, tell me. If you don't want to do it anymore, I want to know. Giving them at the beginning of this exam, nothing I'm doing right now should hurt. If I'm hurting you, let me know so that I can do something different. These are really important. And the conversation before it all happens is the most important. We need to be on the team. You need to know that I'm not going to force you to do anything. We need to discuss what you're worried about, what your anxiety level is. As somebody who is medically anxious, I get it. We need to talk about what we're going to do. And if I recommend biopsies, how I will proceed with that if you consent to the process. They are very, very important. And so the line of communication here, I think, is the biggest factor in how people do with that process. So the biopsy result, if you had to do a biopsy, so if I look with the colposcope and I think, okay, someone came in when they had low-grade abnormality on their smear, and now I'm looking through the microscope and yep, it looks like a low-grade abnormality, then maybe I won't necessarily do biopsies because what I'm seeing matches with what the smear said. That might change depending on someone's age, history, HPV, positive, negative, etc. But in general, if I see what I think I should see based on what the smear said, then I'm not necessarily going to do a biopsy. If someone comes with a high-grade smear and their cervix looks completely normal and they're HPV positive, especially for a high-risk strain, then I'm going to be thinking like, this doesn't match. Why is the smear seeing high-grade abnormality and I'm not? Maybe we should see about doing some biopsies in case I just can't see it. Or maybe we should do another smear, or maybe we should review the smear with the pathologist. There's a lot of different ways that can go. And if someone comes in and they have a biopsy done, those results are going to come back as CIN, so cervical intraepithelial neoplasia, 1 to 3. And that's just a ranking system of low grade, medium grade, which is considered high grade and should be treated in most people, or 3, definite high grade. You can also get back results like squamous cell cancer or adenocarcinoma, glandular cancer. Different kinds of cancers also come up on these. That's the whole purpose of doing this. Mild changes like low-grade abnormalities in most people will get better on their own, and high-grade changes generally should be treated. Treatment options would include what we call an excisional treatment. So that would be something like a Lillette's or a LEAP, which is the same thing, just different acronyms for the same thing. Essentially just a bigger biopsy of the cervix. We can do that with local anesthetic, which is injected in the clinic. And most of the time it's a short procedure. I can get somebody very comfortable. Almost all of my patients leave and say, that wasn't fun. I wouldn't want to do it again for fun, but it was fine and less terrible than I expected. Or if someone has a cervix that's hard to see, or the lesion's in a difficult place, or they are highly anxious and just cannot go through the procedure in the clinic, then we can also do it under an anesthetic in the operating room, either conscious sedation or general anesthetic. You can also have what we call an ablative treatment, but this is much less common now. We used to do it a lot more, cryotherapy, freezing, etc., but we don't do that a whole lot anymore. Usually, if you need treatment for a high-grade abnormality, we're going to recommend doing that with either a LEAP, a LETS, same thing, just one way of doing a bigger biopsy, or a cone biopsy. Cone biopsy is used in particular circumstances, which I won't get into the nuance of, but does have to be done under a anesthetic in the operating room. So either a spinal anesthetic or a general anesthetic. Again, the ablative treatments, although still an option, a lot of places still use them some, but cryotherapy and laser are far less common these days. I don't do any of them because we have better data on effectiveness and safety with regards to LETS/LEAP. I generally will choose one of those or conization because the data and clearance efficacy is higher, but it's not illegal to do laser or cryo. It's still important, even if you have an abnormal smear, or even if you have biopsies and then you need a LEAP or LETS, to go ahead and get the HPV vaccine if you have not had it and you fall into a category that would qualify for it. So in the US, I think it's approved up to age 45, and I don't know how insurance coverage works for it, but if you haven't had it, you should just go ahead and get it. And especially if you have tested positive for HPV or required treatment, or your smears are abnormal, go ahead and get it. There is some data that says it might help in those cases, but it also can prevent you from getting another strain of HPV, which can cause problems in the future. So highly, highly recommend HPV vaccination. Again, that 3-part series is linked below. go watch it after this one if you have questions about HPV vaccine. Treatment would generally just be done in clinic like we talked about, except in certain circumstances, and recovery is usually a few days of crampy, weird discharge, bleeding for a couple of weeks. So it shouldn't be really heavy bleeding and it shouldn't be really heavy discharge, but it can go on for a couple of weeks. We recommend nothing in the vagina, so no toys, no tampons, no intercourse, etc. in that healing period of a couple of weeks. And once we get the results back from that treatment, whether it was a conization or a excision biopsy, we will give you a ring, let you know, hey, this is what the result was, and here's the recommended follow-up. I hope that answered your questions. I cannot possibly claim that I have gone through everything that we need to talk about on this subject, but I hope it's a good primer. I hope that it prompts more conversation or gives you at least a basis of things to talk about with your OB-GYN or advanced practice provider or smear taker or whoever's taking care of you. If you have any questions, I would love to hear them. Please leave them in the comments below. If you learned something, I'd love to know that too. If you're new or you're not new and you look down and you're not subscribed and you want to be, we would love to have you. Thanks for being here today, y'all. I'll see you next Monday.